A 36-year-old man presents to the emergency department with a 2-week history of progressive shortness of breath and lower extremity swelling. Echocardiogram shows globally reduced left ventricular function with an EF of 25% and severe dilatation of the left ventricle with evidence of increased left ventricular end diastolic pressure. Which of the following is a strong predictor for a worse outcome in this patient's condition? Pattern of troponin elevation, echocardiogram findings, age, heart rate, and recent flu-like illness. This is actually a pretty interesting one. The fact that this patient is 36 years old does make me think of some kind of like myocarditis causing a heart failure picture. And in that case, I'm actually not sure what the worst prognostic factor would be. Maybe it would be something like the pattern of troponin elevation, but let's see. He reports a flu-like illness about 6 weeks ago. There does not appear to be any significant past medical history. He denies smoking or alcohol use. His medications include over-the-counter ibuprofen taken during his recent illness. His vital signs are pretty normal. He's got all the signs of heart failure. His troponin is 1.8, which is stable over the past 6 hours, and BNP is 880. EKG shows sinus tachycardia with no ischemic changes. Yeah, so I think I've had a couple of patients with myocarditis. Usually it was from the immune checkpoint inhibitors that we're now starting to use for immunotherapy for cancer. And some of those patients, their troponins just continued climbing. And I feel like that's probably the most significant prognostic factor for a worse outcome. Echocardiogram findings, I feel like could be an answer, but there are some patients that get, a really low EF, 25%, and it recovers. The fact that he's age, I doubt is the right answer because, the patient's only 36. If anything, that should be a good prognostic factor. Heart rate, not that I know of, and the recent flu-like illness, I don't think is the correct answer here. So pattern of troponin elevation is incorrect. It is actually the echocardiogram findings. So honestly, this one's kind of a specific one. I really could have gone with B as well. It's just I've seen some patients with myocarditis where the troponins kept elevating a lot. So this is one that I didn't know. A 22-year-old previously healthy man was found unresponsive following an opioid overdose. He has no eye-opening, spontaneous movements, or response to stimulation. Blood glucose and electrolytes are normal. Which of the following is the most important next step in evaluation for brain death? Increase his blood pressure, initiate transcranial Doppler testing, increase body temperature, begin EEG, and obtain a head CT angiogram. So you cannot call brain death if the patient is hypothermic. There's a few situations where you can't call brain death. It's like if the patient's hypothermic or if they're still, in a shock, like state with high hypotension. But blood pressure of 104/57 is not low enough that would preclude you from doing a brain death exam. Regarding imaging, sometimes you can get an MRI and you'll see like complete loss of gray-white differentiation. But in this case, the head CT was already concerning for diffuse hypoxic injury. So I don't think we need another head CT. EEG, we sometimes do a couple days after the patient's been admitted, just to give prognosis. If there's some brain activity, that's a little bit of a better prognosis than if there's like seizures and things like that going on. But again, it's not part of the brain death exam. Transcranial Doppler testing, that's looking for blood flow in the brain as well. None of these are correct answers for brain death. So we are going to do increase the body temperature. Okay, so exclude metabolic and toxin confounders, ensure core temperature is greater than 36, and ensure systolic blood pressure is greater than 100. So it looks like these other tests, the transcranial Doppler testing and the CT angiogram and EEG, they're all kind of ancillary tests that you can get. But in this specific instance, we can just do the brain death exam first. And, you only need some of these tests if all brain death criteria are not met. A 58-year-old woman presents to the clinic with complaints of generalized fatigue and chronic knee pain. Urine sediment exam shows 10 to 20 white blood cells per high-powered feel and granular CAS. So she's got ATN. The white blood cells can make you think a little bit of acute interstitial nephritis, but the granular CAS is basically the same as muddy brown CAS. So think about ATN. Renal ultrasound shows normal-side kidneys without hydronephrosis. Which of the following is the most appropriate next step in management for this patient? Start corticosteroids, start an ACE inhibitor, start nitrofurantoin, perform a kidney biopsy, or discontinue ibuprofen. So this patient is taking a lot of ibuprofen, it looks like, for knee pain, and she's basically getting acute renal failure from it. And she's got ATN, she's got white blood cells. NSAIDs are a very, very common cause of acute interstitial nephritis. And if you leave it for too long, it will also progress to ATN, acute tubular necrosis. So almost certainly the answer here is ibuprofen in the context of starting ibuprofen about 6 weeks ago. No need for a kidney biopsy. She doesn't have a UTI, although she's got some positive leukocyte esterase. This is not consistent with the UTI. She's got no dysuria that we see here. We would not start an ACE inhibitor unless this was CKD, and steroid therapy would only be if we're thinking some kind of autoimmune process. So discontinue ibuprofen is correct here. A 54-year-old woman presents to her primary care physician accompanied by her daughter, who is concerned for her mother's well-being. Over the past 4 months, the patient has lost interest in cooking and playing the piano, activities she once cherished. So immediately we're starting to think of geriatric depression, very common, and yeah, that's really the biggest thing. You can start having dementia leading to these kinds of things, but in a 4-month time span, I think geriatric depression is probably a very, very high risk here. Although the patient's only 54, so let's see what else is here. The patient's father, to whom she was very close, died suddenly 14 months ago from a heart attack. So you could start thinking of some kind of bereavement or grief disorder, but 14 months ago, and the fact that her symptoms started 4 months ago, the timing might not be totally in line. So her vital signs are as follows. The vitals all look good, and physical exam is unremarkable except for psychomotor retardation. Reflexes are normal. Urine toxicology is negative. So what is the following most likely diagnosis? Major depressive disorder, hypothyroidism, adjustment disorder with depressed mood, persistent depressive disorder, and bipolar disorder. So immediately, I'm not seeing anything that's looking like hypothyroidism just based off her vitals alone. We would be thinking of some hypothermia, some bradycardia, things like that. And she would also have hyporeflexia. Bipolar disorder, I'm going to start looking for any signs of mania. You need to have, if you're going to have bipolar disorder, you need to have manic episodes and your depressive episodes. Persistent depressive disorder, adjustment disorder. So adjustment disorder usually is within 6 months of the precipitating factor. I'll have to look that up to confirm, but this is probably unlikely given that the inciting event was 14 months ago. And major depressive disorder, like I said, just very likely for her, SIGI CAPS, if she fulfills all those criteria, then this would make a diagnosis of major depressive disorder. So she struggles to stay focused, so that's lack of concentration, forgets simple tasks like paying bills, sleeping excessively, complains of constant tiredness, so low energy, excessive sleepiness. She has lost 10 pounds over the past 2 months, denies feeling of guilt, worthlessness, or thoughts of suicide, denies heat or cold intolerance or constipation, has a past medical history of hyperlipidemia, which is controlled with atorvastatin, and shoulder pain from a childhood injury, which is reasonably well controlled with ibuprofen. She admits to more frequent ibuprofen use over the last several months, uses alcohol socially, and never used recreational drugs. So in the absence of anything else, we're not seeing any bipolar disorder. I don't totally know what the criteria is for persistent depressive disorder, so I'm just going to go with major depressive disorder here. So adjustment disorder, they're saying, is within 3 months of the acute stressor. Persistent depressive disorder is dysthymia. Okay, so that's the kind of low-grade depression that lasts at least 2 years. You can see here, adjustment disorder must have onset within what time frame of stressor? Within 3 months. And if you are greater than 5 of SIGI CAPS, even if you're within 3 months, you're just automatically considered major depressive disorder. And just to quickly review, so complex bereavement. So you can have intense yearning for the deceased that persists at least 6 months to a year after the loss, which is called complicated grief or persistent complex bereavement disorder. Patients can actually have a little bit of not really true hallucinations, but like feeling like their significant other was there, or that they heard their significant other, or felt like they were around. And that's actually not considered psychotic. So you can see here that sensing a loved one who has passed, hearing their voice, or catching a glimpse of them can be sensory experiences known as bereavement or grief hallucinations. Many people find these moments comforting. In fact, grief hallucinations are considered by some experts as a common feature of the bereavement process. A 42-year-old woman with a history of autoimmune disorders and intermittent diarrhea presents to her PCP with complaints of a 3-day history of tingling around her mouth and in her fingertips. Looks like she's got hypocalcemia, so this is probably Schwarzkopf's sign, which is like the perioral numbness, which is one of the first locations that you start to notice hypocalcemia symptoms. So which of the following is the most likely mechanism for this patient's hypocalcemia? Enhanced deposition of calcium in bone tissue, parathyroid hormone secretion failure due to autoimmune destruction, impaired activation of vitamin D in the kidney, parathyroid hormone resistance at the renal level, and malabsorption of calcium in the intestines. So this one, enhanced deposition of calcium in bone tissue, makes me think of osteitis fibrosa cystica. I believe that's the diagnosis there. Maybe Paget's disease could fit with this. Parathyroid secretion due to autoimmune destruction, very common, especially in a pretty young woman who has autoimmune history. Impaired activation of vitamin D in the kidney. That would be if somebody's got like kidney failure. Parathyroid hormone resistance at the renal level, I think, is the pseudo hypoparathyroidism diagnosis, which is like an autosomal dominant disorder that's seen in children. And malabsorption of calcium in the intestines could be the case, if she's got like some kind of malabsorption, celiac disease, although calcium isn't typically one that I associate with celiac disease, but it could be. She's got intermittent diarrhea, remember that. So she's been experiencing muscle cramps and recent worsening of hair and skin quality. This is kind of making me think of a malabsorptive process because hair and skin quality could go a little bit more with some other vitamins and minerals, namely zinc and copper. Current medications include methotrexate, folic acid, hydroxychloroquine, prednisone, and loperamide as needed. Her vital signs are normal, and she's noted to have Schwarzkopf's sign and carpal pedal spasm when the blood pressure is inflated, so the Trousseau sign. And let's see. So her vitamin D level is normal, her intact parathyroid is normal, phosphorus, magnesium, and albumin are all normal. So I'm actually not sure about this. For some reason, I'm thinking of malabsorption because of the worsening hair and skin quality. And she's got methotrexate. I'm trying to see if any of these medications could be causing worsening absorption. So methotrexate, folic acid, hydroxychloroquine. I'm not sure. I mean, the autoimmune destruction also is very likely because of her autoimmune history, although she is on quite a few medications to prevent autoimmune diseases, namely the methotrexate and hydroxychloroquine and prednisone. So one thing I am just noticing now is, if somebody's hypocalcemic, you would expect their parathyroid hormone to be elevated. So the fact that the intact parathyroid hormone is just in the normal range is actually abnormal. The correct response to hypocalcemia is to increase your parathyroid hormone, thereby increasing the level of calcium in your blood. So the fact that this is only within the normal range rather than elevated is an inappropriate response, and that mainly points to parathyroid hormone secretion failure due to autoimmune destruction. So I'm going to go with this answer, and you can see 74% of people got it right. You can see exactly like I said, the inappropriately normal PTH in the context of hypocalcemia suggests a problem with parathyroid hormone production or secretion. Check out my recent video on hypercalcemia if you want to do some more review. I didn't do a video on hypocalcemia yet, but again, you always have to pay attention to that PTH level, either in hyper or hypocalcemia. Right, and malabsorption was not the correct choice because you would also see a reduction in vitamin D levels as well, and you would have an elevated PTH. A 54-year-old woman presents to her physician's office with a 3-month history of persistent lower back pain and fatigue. Lab results are shown, peripheral blood smear is shown, and SPEP shows a large monoclonal spike in the gamma region. X-rays of her spine show multiple lytic lesions, and there's 45% plasma cells. So she has multiple myeloma, and she fits all the criteria, the CRAB criteria. So she's got hypercalcemia, she has renal insufficiency, she's got anemia, and she's got bone lesions. And then here you'll see the classic Rouleau sign, where you've got those stacked red blood cells, like as if they're coins on top of each other. So which of the following is the most appropriate next step in the management of this patient? Chemotherapy, corticosteroid therapy, radiation therapy, plasmapheresis, and IV bisphosphonates. So the initial treatment of multiple myeloma, I feel like bisphosphonates could be an answer because you want to reduce the risk of skeletal complications. But the calcium level is really not that high, 11.2. And so you probably could just initiate treatment right away. Now, the question is, what is the initial treatment? And probably I'm thinking is just starting them on chemotherapy, because radiation therapy, you're not going to treat multiple myeloma, which is like a diffuse, it's a liquid cancer. You're not going to be able to irradiate the whole body. So I'm kind of knocking that out. Steroids, I don't think is like a first, you're not going to just start treatment for multiple myeloma with steroids, I believe. Plasmapheresis, I would think of if somebody had like very, very severe lab abnormalities, like really bad AKI progressing to dialysis, because maybe you need to get rid of some of those monoclonal proteins that are going around causing a kidney injury. So, and then I think bisphosphonates again is like later down the line to prevent skeletal complications. So I'm going to go with chemotherapy, but I'm not totally sure. And 66% of people got this right. So radiation therapy is mainly for palliation of symptoms related to plasmacytomas. IV bisphosphonates are an adjunct of therapy, which are given later. Plasmapheresis is only in the case of hyperviscosity syndrome, and steroids alone are not adequate. They are often included as part of the chemotherapy regimen, but not used as monotherapy. A 67-year-old man presents to the emergency department with chest pain for the past 2 hours. Here's his EKG. He's got an elevated troponin, his creatinine is normal, and his GFR is actually really low. So he must be a very, very small guy. And he's got ST elevations in leads V1, V2, V3, V4. Also has some ST depressions in V5, V6. In the inferior leads, these are all ST depressions. So he's definitively having a STEMI. And it's kind of in the anteroseptal leads. Which of the following is an appropriate component of antithrombotic therapy for this patient? Streptokinase, prasugrel, abciximab, enoxaparin, and unfractionated heparin. So in our institution, we basically start all of these patients on heparin. Streptokinase is going to be a TPA, which you would kind of give if you're at an institution that does not have access to stenting. Prasugrel is a PTY12 inhibitor, and it could be a reasonable choice. But really, the most important choice right up front is to get them on full anticoagulation to prevent any further clot progression. Abciximab, again, is kind of another platelet inhibitor, which we would give after we start them on anticoagulation. And then enoxaparin, I think when I was actually prepping for my CCU rotations, there actually was some evidence that Lovenox could be used in the setting of acute coronary syndrome. But in this case, I really like just doing heparin because it's quick on and you can just get the levels up really quick and you can turn it off really quick if you need to. And so that's the choice I'm going to go with here. I'm just reading the question really quickly to see if there's anything I need to add. He's got a PCI, he got a drug-eluting stent, he's on aspirin, metoprolol, and atorvastatin. He's already been giving atorvastatin. Closest PCI hospital is 20 minutes away. So if the closest PCI hospital, I believe, is less than 90 minutes away, I'll have to review my video on this, but if it's 90 minutes away, then you would consider lytic therapy. But because it's only 20 minutes away, they can transfer him and get him to door to balloon. Or maybe it's 120 minutes. But anyways, they should be able to transfer him and get him a stent. So let's just get him on heparin. Okay, yeah. So he can't use Lovenox because of his renal dysfunction. And streptokinase, again, where another facility would exceed 120 minutes first medical contact to balloon time, then you would use TPA. A 71-year-old woman is brought to the emergency department by her daughter, who found her in a confused state, and the EKG shows low voltage QRS complexes. Which of the following is the most appropriate diagnosis? DKA, myxedema coma, hypoglycemia, Wernicke encephalopathy, and uremic encephalopathy. Of these, I already can tell you that the one that's associated with low voltage QRS complexes is hypothyroidism. So I'm immediately going to go up to her vitals. She's hypothermic, she's hypotensive, she's bradycardic, and she's also bradypnic. I don't use that term very much. Bradypnic, is that actually even a term? Why does that sound so weird? Bradypnic. Okay, it's just really hard to say. So yeah, she had Graves' disease, she had radioactive iodine ablation. It's all pointing to thyroid, and she's been increasingly lethargic over the past few weeks. Blah blah blah. Definitely myxedema coma. There's actually a score that you can calculate for myxedema coma. Basically, you can actually look up the scoring criteria for myxedema coma, and based on how many points they get, it can help you make the diagnosis of myxedema coma or not. A 68-year-old woman presents to the clinic with episodes of dizziness and near syncope over the past month. EKG is shown, hemoglobin is fairly normal, creatinine is slightly up, and her glucose is slightly up, but nothing too concerning. And then on her EKG, so let's go through it systematically. So her rate, so she's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 times 6 is what? 78. And so 78 beats per minute. And then the rhythm, is it a regular rhythm? Well, it looks like it's pretty regular. And then we have this beat, which is a little late, and then this beat. So we're going to check if it's sinus. So we want to look for a P before every QRS, P before every QRS, P before every QRS. And then here, it looks like we have a little bump here, but no QRS, and then we're back into sinus. So it is sinus because we have a P before every QRS and a QRS after every P. In terms of the axis, it's upright in lead 1 and upright in lead 2, so it's a normal axis. And intervals, it's a normal PR interval, normal QRS interval, normal QT interval. And then morphologies, do we see anything abnormal in the morphologies? So do we see signs of right atrial enlargement, which you'd see with a tall P wave here? No. Do you see signs of left atrial enlargement, which you see like a really broad-based bifid P wave here? We don't really see that here, and we don't see any signs of that in lead V1 either. So do we see signs of left ventricular hypertrophy? No. Do we see signs of right ventricular hypertrophy? Also no. And we don't see any crazy ST changes. So overall, fairly unremarkable EKG, except for this potentially dropped beat here. I'm not totally sure what to make of that. Which of the following is the most appropriate diagnostic study at this time? A tilt table test, echocardiography, 24-hour Holter monitor, serum cortisol level, or a carotid sinus massage. So carotid sinus massage would be if she's in supraventricular tachycardia, either AVNRT or AVRT. So that's not correct. Cortisol level is really not part of a typical workup for syncope, so I'm already really not thinking about this. Tilt table test is going to be reserved for, really unclear situations where you can't figure out what's going on. And then echocardiography would be if patient has signs of a new murmur that hasn't been worked up, or signs of severe valvular disease that could cause syncope. So probably a 24-hour Holter monitor is the most appropriate. These episodes occur when she stands up from a seated position. So that's making you think of orthostatic, especially in the morning. So people tend to be a little bit dehydrated in the morning. She has a history of hypertension, type 2 diabetes, and osteoarthritis. She's on lisinopril, metformin, and ibuprofen. Blood pressure is 130/80 and 118/72 after standing for 2 minutes. So that does not meet criteria for orthostatic hypotension. You'd want to see a drop in the systolic blood pressure of greater than 20, or a drop in the diastolic pressure of greater than 10. And a heart rate went from 72 to 78. That's also pretty reassuring. You should have a compensatory increase in your heart rate after standing. If it's greater than 30, that can sometimes suggest postural orthostatic tachycardia syndrome, or POTS, which is what you would use a tilt table test to diagnose. But this is really just a very mild increase, and so that's also not concerning. She's got some trace lower extremity edema bilaterally, but is otherwise unremarkable. So in this case, the lower extremity edema bilaterally is starting to make me think of echocardiography. So maybe we can get an echo, because why does she have edema? She's not on amlodipine or something. And then the fact that she's getting this after standing from a seated position, we're really not getting anything suggesting she has an arrhythmia other than this like delayed beat right here. And so maybe she does have some aortic stenosis, which is causing her to have a blood pressure drop when she stands too quickly. And that's why she has some lower extremity edema. Although with aortic stenosis, we would probably see signs of left ventricular hypertrophy. I don't know. This lower extremity edema is throwing me off a little bit. Both of these tests we do tend to get in patients. I don't know. I could make an argument for both of these, but maybe I'm just going to go with echo just because we're not getting anything suggesting arrhythmia here. She's getting dizziness. She's having these symptoms. Gosh, I really don't know. And it's a tilt table test. Interesting. Oh, a tilt table test is indicated in this patient with orthostatic intolerance for whom there is a high degree suspicion for orthostatic hypertension based on the history, despite absence of a significant BP drop with simple measurement on physical exam. We kind of went over the orthostatic vital sign diagnostic criteria. And if the patient experiences a significant drop in blood pressure with reproduction of symptoms, such as dizziness or fainting during the test, it is diagnostic of orthostatic hypotension. Okay, interesting. I did not know that. So if your suspicion based on the history is high enough for orthostatic hypotension, then that would be when a tilt table test is indicated. The EKG shows sinus arrhythmia, so it's basically just the sinus rhythm varying with respiration. Okay, so let's see what UpToDate has to say. Indications for tilt table testing. The upright tilt table test is a component of the evaluation of selected patients with syncope. The role for tilt table testing is limited since the initial diagnostic testing is often diagnostic in patients with vasovagal syncope, and tilt table testing has limited reproducibility and diagnostic accuracy. However, a positive test that reproduces patient's symptoms may not only be helpful diagnostically, but may also increase patient confidence that an accurate diagnosis has been made. With the understanding that tilt table testing is an imperfect diagnostic test requiring experience interpretation and that clinical practice varies, tilt testing may be included as part of a complete syncope evaluation for selected patients in the following settings. Syncope of unknown cause, for example, for recurrent syncope or single episode with high risk of physical injury should syncope recur. Suspected vasovagal or orthostatic syncope, or evaluation of autonomic system dysfunction. So interesting. I actually did not really know that, because I just so rarely order tilt table tests for the evaluation of syncope, because we kind of just rule out the concerning things inpatient first. But in this case, this is a great learning point for me. So I'm going to make an Anki card out of it. So Conan PGY5. When is tilt table testing recommended for evaluation of syncope of unknown cause, or high suspicion for orthostatic vagal syncope? Also for evaluation of autonomic system function. For example, if history is very suggestive of orthostasis, but it is not confirmed on vitals. Syncope of unknown cause includes recurrent syncope and syncope single episode of syncope with high risk of physical injury should syncope reoccur. All right, and we'll add that card. And we'll do one more quick question to end on a correct answer, but it is satisfying to learn something from these questions, so I'm glad we were able to make a little card on that. And a 44-year-old woman presents to the office with a 6-month history of diffuse musculoskeletal pain and constant fatigue that seems to be worsening. This almost sounds kind of fibromyalgia-esque, the fact that it's like diffuse and fatigue. All of her, physical exam looks normal, but she's got generalized tenderness to palpation in multiple body regions, which is, again, a diagnostic criteria for fibromyalgia. It's like multiple tender points and then a global fatigue score. Lab studies are all normal. So all of this is kind of screaming fibromyalgia. Which of the following is the most likely diagnosis? Rheumatoid arthritis, fibromyalgia, lupus, polymyalgia rheumatica, and polymyositis. So polymyositis, I would suspect some kind of association with cancer. We would see potentially some skin findings. You see the mechanics hands and things like that with dermatomyositis. I'm forgetting if polymyositis, you also get all those skin findings, but that's less likely here, especially with all of the normal workup. Polymyalgia rheumatica, she's got normal ESR and CRP, which are, what can be used to diagnose polymyalgia rheumatica. And you would see that in patients who are typically older and have potentially temporal arteritis. Lupus, again, unlikely with all of the normal exams. And rheumatoid arthritis, also probably unlikely in the absence of any significant inflammation. So this is definitely fibromyalgia. Okay, and just some other details. So rheumatoid arthritis, remember, it affects the small joints of the hands and feet generally. And morning stiffness that improves with activity is characteristic. Lupus will have the classic malar or butterfly rash and photosensitivity, as well as involvement of multiple other systems. Polymyositis is going to be proximal muscle weakness rather than pain, and tends to be symmetric, developing over weeks to months, and they may have elevated muscle enzymes and liver enzymes. And polymyalgia rheumatica is again going to be in older adults with aching and morning stiffness in the shoulders, hip girdle, and neck. And this is not usually widespread and does not have associated symptoms like non-refreshing sleep or cognitive difficulties. All right, that's it for today. Thanks for watching. I was a little tired this time because I didn't sleep very well last night. I went to bed really late, but I thought I wanted to get a video out for you guys. So hopefully it's still useful and hopefully it's still a good review for you guys. I tried reading the questions a little bit more quickly and just kind of skimming through them because I want to keep the video shorter for you guys and get through as many questions as possible. So let me know if that's okay, that I wasn't like reading all of the question stem here. I was kind of just skimming through it, which is kind of how you do it on the test as well. Thanks again for watching, and I'll see you in the next one. Peace.